We've talked about psychological and behavioural approaches to the patient consultation. Is there any evidence of this working in practice?
There have been a number of studies that have applied these approaches in pharmacy settings. One of the classics was led by Nick Barber at the School of Pharmacy. It's over 10 years ago now. But a more recent one by the Belfast group with Prof. McKelney showed that pharmacists phoning from hospital prior to patients' discharge in community could also apply these approaches with significant improvements in patient adherence, but also in other outcomes such as reduced readmission to hospital. So pharmacists can be very effective at applying insights from psychology and behavioural medicine to their practice.
I see. But how can you know what's going on in the patient's head? Can you give us an example, perhaps, or a situation where this kind of approach works?
I think the core question that you asked there, Christine, was, how can we tell what the patient brings, what's in their head, without saying, tell me what you're thinking. So an example which I've seen and used many times is often when a community pharmacist hands the prescription to the patient, they'll ask a question like, have you had this before? And if the patient says yes, they'll assume that, they know what they're doing and they'll hand them the prescription. But I would suggest a very simple alternative to that, which is, first of all, to say, hello, I'm your pharmacist. I'm looking after your medicines, helping with your medicines. Can I ask if you have any questions or concerns about this medicine? And what I found in my practice and in the research studies we've done is if you just say that to people, they will often tell you what is on their mind. So it's just, do you have any questions or concerns about this? Or is there anything I can do to help you with this? Are you okay with it? Most people will say, I'm fine. But often when the person does have concern, they will address the question. Now, there are lots of other initiatives that I think one could develop for community pharmacy, which would encourage the public to see the type of support that they can get from the community pharmacy is maybe a lot more than they might expect. So it's not just what the individual pharmacist says, but maybe there is more that we could be doing in terms of how pharmacy presents itself to the public and what it says to the public about what you can get from a pharmacy.
I see. But is this kind of approach realistic with the current business model for community pharmacy?
No, I think it is a reasonable question. The question of what can we do within the current business model is really relevant, okay? Could I answer that in two parts? Could I first address what I think we could do based on evidence, and then say, right, is the current business model fit for purpose for rolling that out? So the first question, what do I think we can do? Well, you only need to look at the new medicine service in the UK as an example. That was based on an earlier study that we did applying these approaches at the School of Pharmacy, led by Nick Barber, a colleague of mine. And what we did was to apply the idea of understanding the patient's beliefs as well as their capabilities, so their perceptions as well as the practicalities around medicines. And then in a brief phone call from the pharmacist, typically about 10 minutes max, we were able to address those belief barriers and practical difficulties in a way that led to a significant improvement in adherence, engagement with the treatment. And that was a proof of principle study that showed that you can apply behavioural interventions through a pharmacy channel. it was the foundation, it was the inspiration for the New Medicine Service. Now, one can then ask, where else could this go? So if you look at the current scenario in most health economies, there is a shortage of access to doctors. There is a need for more preventative care and better self-management of conditions within the community. And I believe that pharmacists could have a much greater role in this. They are well trained scientifically, they're accessible, and there's lots of them. And I think it's amazing how little we use pharmacy. So if you look, for example, at musculoskeletal pain control and the huge societal impact of that, I believe that pharmacists could be more involved, and using the tools that they have at their disposal on the P medicine shelves could probably do a lot more to support pain control. And that includes not just the medicines, but other psychological tools and techniques that you should be able to access in your pharmacy.
Right. So what are the implications for the business model?
I'm not by any means an expert in this area, and my observations come from a UK-centric observation, probably uneducated of how pharmacy is funded, and talking to my colleagues. But what it really seems to me is that we have a rather old-fashioned and, dare I say, outdated way of remunerating pharmacy through the NHS, which is based on the volume of prescriptions. That, I have to say, is so last century. It's almost beyond the last century. And it emphasizes a role of the pharmacist, which is about the safe supply of medicines. Very important, but actually we could probably automate that in the next few decades. And it fails to recognize the huge contribution that pharmacists can make in how medicines are actually used by patients, but also wider issues around community management. What about prevention? There are issues there that I believe pharmacists could take a much bigger role in, and we need to have a remuneration model that is fit for a 21st century public need and a 21st century pharmacy capability. I think I'm probably talking more in the realm of the apothecary role than the pharmacist as a person who is limited to safe supply. As soon as we say safe supply, it implies a clinical role. They have to engage with clinicians. Is this the right prescription? And they have to engage with patients. Are they able to take the treatment to best effect? So the apothecary role is in a way an extension of safe supply, but it goes wider. Just funding pharmacy on the basis of safe supply is, in my view, a missed opportunity for governments and society.